All right. So we're going to turn our attention to pediatric orthopedics, because not all children bounce.
Okay, and let's start with Salter fractures. So the concept here is basically the growth plate, right? It's the physis. And this is composed of cartilage cells. You can't see it on x-ray, but it's really important because it can impede growth. So this is weaker than the supporting ligaments, and the blood supply to the growth plate comes through the epiphysis. And so, damage to the epiphysis is also worrisome, and we're going to talk about the different types of Salter fractures that you can have. Okay, so here's our Salter mnemonic. I love mnemonics that use the word that it is to describe it. So here, S, that's the first one, that's a slip through the growth plate. The second one is A for above the level of the growth plate. The third one, this is L, this is lower than the growth plate. The fourth one is T through the growth plate. And the fifth one, that rams the growth plate, so this is a crush injury. This is just showing you an example of grades 1 through 5, and then basically through the mnemonic we just talked about.
So Salter fractures, are seen in long bones in kids, and that includes fingers. So that can be kind of the subtle one that you can't forget about. All of these involve either the growth plate or the joint surface. And the thing you're really worried about here is growth complications, right, that cause some permanent impairment or disfigurement. X-rays can be negative for types 1 and type 5, right? Salter 2 is the most common Salter type of fracture. So here's a Salter 1. It's pretty subtle, but you can see there's a little bit of a slip there. Type 2, remember, this is the most common. So in the mnemonic, it's above, but what it really is it's proximal to the growth plate. Type 3, right, so this is below or distal to the growth plate. Type 4 here, I think you can see that the fracture line extends through the growth plate.
So let's talk about supracondylar fractures. So this is one of the most common injuries in kids, and so it's really important to think about if they're having tenderness above the elbow. So the complications you need to worry about are things like injury to the brachial artery or median nerve, which run right past that area. You also have to worry about forearm compartment syndrome. And then the thing that we look for in x-ray is we look for the fat pad sign. So we always say that an anterior fat pad sign, that could be normal, but the posterior is always abnormal. So I like to think that posterior is a problem. And then, displaced fractures can sometimes require hospitalizations because they need neurovascular checks. They may be taken to the OR. And even if a patient has tenderness in the area and you see this fat pad sign, but no fracture on exam, you're still going to splint these patients and have them follow up. And here are some examples that we just talked about of the anterior and then the posterior fat pad sign.
What about the anterior humeral line test? So this is used to pick up occult supracondylar fractures, right? So draw a line down the anterior humerus. Normally, it bisects the middle third of the capitellum. In abnormal, it's going to pass right in front of the capitellum or bisect the anterior third, and you can see that in the photograph on the right. Here's another couple examples of the anterior humeral line test comparing normal to abnormal.
So subluxed radial head, this is your nursemaid's elbow, right? And the history here is like, parents or caregivers swinging the kid, or kid goes to, run into the street and they grab them real quick. And so, typical ages for this is around 1 to 4. X-rays are not necessary. There's different reduction techniques that you can use. And I personally love this, right? Because this is a time that we can actually fix the patient. And, my one hero story is I had a kid, I was at a wedding, and the ring bearer had, the nursemaid's elbow, and it was me and a pediatrician. I offered it to them, and they were like, no, you go. And I was able to get it back. And then, the kid was in the wedding, and I think I saved the day. I don't know.
I think you did. I think otherwise those people would never have gotten married.
Yeah, probably.
Okay. How about buckle and greenstick fractures, right? These are sort of unique to pediatrics. So a torus fracture, a buckle fracture, that means the cortex of the bone is buckled, but it's otherwise intact. This is splinted. Greenstick fracture, so the cortex is disrupted on the other side, and it's intact on the other. Acceptable degree of angulation varies by age.
So leg calf Perth's disease. So this is idiopathic avascular necrosis of the femoral head. More common in boys than girls. Typically, the age is 4 to 8. Patients can present with a lip, hip pain, so the x-rays can be normal, so you can consider MRI in these patients. Bone scans diagnostic, not something we typically do in the ED, but these patients are afebrile. If you check the ESR CRP, it's typically normal, but this is one of the things to think about if patients are presenting with pain and a limp. This is just showing you an x-ray. In any of these patients that we're evaluating in these kids, you want to look at both sides. So they'll do this frog leg view so you can compare, each joint.
How about slipped capital femoral epiphysis or SCFE, right? This is classically an obese male adolescent between the ages of 10 and 16. Nobody really knows exactly what has happened. It can happen on both sides. Sometimes the pain is referred to the knee. Onset is gradual, and the x-ray, as you're going to see in the next slide, looks really kind of like a melting ice cream cone. You want to get an AP and a frog leg view. Treatment here is orthopedic consultation and fixation. And there you can see that the capital femoral epiphysis on the patient's left leg is just slipped off. It looks sort of like the ice cream falling off the cone there.
So septic arthritis. So this is actually one of the most common causes of a painful hip in infants. It can be caused by hematogenous spread. So most common is Staph aureus. Anytime you see, painful joint and sickle cell patient, if we're worried about septic, you want to think about salmonella. If they're an adolescent, you want to think about gonorrhea. So one of the first steps in evaluation is an ultrasound to look for joint effusion. You can diagnose it by needle aspiration, and this is also in consultation with orthopedics.
How about transient synovitis, aka toxic synovitis? That's sort of a poor name because the kids are not usually toxic from this. This is often after a recent viral infection. Kids show up with a limp, inability to bear weight. They can have a low-grade fever. We've had our son in the ED for this to be ruled out. It's a diagnosis of exclusion. You got to make sure they don't have a septic joint. But the treatment then is supportive. It's fairly benign. And this is the most common cause of a painful hip in young children. Okay, next we're going to talk about Osgood-Schlatter disease. So the technical name for this is patellar tendon epiphysitis, right? This is classically the adolescent male athlete. Thankfully, I was never athletic enough to suffer from this disease. It's insidious in onset. It's self-limited. You can get pain and swelling right over the anterior tibial tuberosity. X-rays may not show anything. The treatment here is NSAIDs and rest and avoiding forced knee extension. And now we have a couple of pictures here. It just shows you can see that prominence right over the anterior tibial tuberosity associated with this. How about Osteochondritis Dissecans? So this subcondylar fracture, nobody knows why it happens. It's an adolescent phenomenon. The medial femur is the most common, and this can cause a lock joint because you have this loose body floating around in there, but x-rays might be negative.
So this next slide is a painful gait in children. This is your great reference slide. It breaks it down by age, so less than 4, 4 to 10, and then greater than 10. And, it talks about toddler fractures, 4 to 10, osteo, and then as we talked about before, the leg calf Perth's disease, SCFE. So I think that this is a good reference slide to use as needed on the exam.